Welcome to today's seminar, which is co-hosted by CRiHHI and BC Cancer. This is the first seminar that CRiHHI has co-hosted with BC Cancer, and I am just delighted to be part of this and that you've joined us today. To give you a bit of background, CRiHHI, which stands for Critical Research in Health and Healthcare Inequities, is a research unit within the University of British Columbia's School of Nursing, which really offers an intellectual space for those within the School of Nursing, as well as within the wider community, who are interested in critical inquiry regarding health and healthcare inequities. CRiHHI really exists to foster a vibrant and supportive research environment for students, faculty, and others engaged in these types of inquiries. Before we begin, we have the privilege of having Elder Roberta Price open our seminar with a teaching and land acknowledgement. This was previously recorded, and she has graciously allowed us to use it today.
CRiHHI OCM, greetings and welcome everyone. I want to share a teaching to start us off in a good way. I have in my hand a cedar headband. I'm going to place it on my head. I have around my neck a cedar necklace. And as taught to me by my elders, that when we put on parts of our regalia and we carry our sacred items, we're given an indication to our ancestors and the Creator that we're going to share in ceremony. So thank you everyone for listening. I'll start us off now in a good way. CRiHHI CM CIA. Greetings and welcome everyone. As co-Salish matriarch and elder, I wish to give a very warm thank you to all my relatives on the Musqueam, the Squamish, and the Tsleil-Waututh for welcoming me to live in the unceded lands of my relatives, Musqueam and Richmond, for 40 years now. As co-Salish matriarch and elder, I wish to give each and every one a very warm welcome who live, work, and play, give and receive service, teach and learn on our ancestral, unceded, and occupied lands of my relatives, Musqueam, Squamish, Tsleil-Waututh. For each and every one of you out in this very wide virtual circle we're in, the teachings I'd like to offer to you is to take time each week or each day to have reflection and give the honor and thanks to all the ancestors of the lands on which you live, work, and play on, give and receive service, teach and learn on. Thank you for listening. OCM.
Well, that is just a wonderful way to open this ceremony. And I would like to quickly acknowledge that this seminar originally was recorded in Vancouver, but I'd like to acknowledge that I come from Manitoba, where I live and work and play and raise my family on Treaty 1 territory, which are the original lands of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and the homeland of the Métis Nation. And so welcome again to this co-hosted seminar. Today I'm going to be talking about health equity, specifically in the cancer care sector. And just to situate myself a little bit, my name is Tara Horrill, and I have just recently started a postdoctoral fellowship funded by Michael Smith Health Research BC. And I'm jointly supervised by Dr. Annette Browne here at the UBC School of Nursing, by Dr. Kelli Stajduhar from the University of Victoria School of Nursing. And I also have a cross appointment at BC Cancer, and I'd like to acknowledge Dr. Leah Lambert, who's been a close collaborator and advocate for my research and more broadly health equity in the cancer care sector. I completed my PhD earlier this year at the University of Manitoba, where my research really focused specifically on equitable access to oncology care for Indigenous peoples in Canada. So just to give you a bit of an outline about what I'm going to be talking about today, I'm going to start by talking a bit about what we mean by health equity, and then talk about some of the challenges to health equity that we see within the cancer care sector, and then how we might move forward towards an equity-oriented cancer care system. And I know that we do have quite a wide-ranging audience. Some will have expertise in health equity, and some have expertise and experience within the cancer care sector. Some likely have both, and some may have none. So I've tried to make this accessible to a wide-ranging audience. So what are health inequities, and conversely, what is health equity? Health equity is very commonly defined as the absence of unfair or avoidable or remediable differences in health among population groups, however those are defined socially, economically, demographically, or geographically, and so on. Conversely, health inequities are those differences in health that are socially produced, they're systematic in their distribution across a population, and they are unfair. Health inequities are really created and maintained by social and structural determinants of health, or more simply, these are the circumstances and conditions into which people are born, grow up, live, and work and age. Social determinants of health, of course, include things like one's living and working conditions, employment and education, income, socioeconomic status, social context, healthcare access, and so on. These determinants of health are really shaped by structural forces, which include things like public and social policy, economic contexts, social values, political philosophy, the isms like systemic racism, colonialism, and so on, and stigma. And very quickly, what is the difference between equity and equality? These terms are often used interchangeably, but they don't actually refer to the same thing. In this context, health equality would mean that each individual or group is given the same opportunities and access to social determinants of health, whereas health equity acknowledges that the playing field is not level. There are some groups that experience disadvantages for many reasons, and therefore may need access to more resources to level that playing field. And so if we take the idea of equity, those with the highest health and social needs should have the highest level of access to health and social services. In reality, we often see the inverse care law at play, where access to healthcare tends to be lowest among those with the highest need. And so what do we know about health inequities in the cancer care sector specifically? Well, we know that there are some quite alarming differences in cancer outcomes for people who are most impacted by health and social inequities. So this might include people who experience the often intersecting impacts of racism, stigma, other forms of discrimination, poverty, mental health challenges, substance use challenges, unstable housing, or disability, and so on. People who experience these types of inequities are also often disadvantaged in multiple ways and end up being diagnosed more often with advanced cancers than people who do not experience these kinds of inequities, and also have higher cancer-related mortality. And in some cases, we are seeing people die from preventable and treatable cancers. So for example, we know that people with severe mental illness will have upwards of a 90% higher odds of an advanced cancer diagnosis than those without a diagnosis of mental illness. We know that cancer mortality is twice as high among adults without a home compared to the general population. And these outcomes are really linked in part to the compounding effects of many factors that really create persistent inequities in access to care at all points along the cancer trajectory. And I'll talk more about the challenges at each point in the trajectory in a moment. The focus of research on inequities in cancer care in Canada has largely focused on associations between demographic variables and cancer. Most often this includes income, sex, age, or geography. But we very often do not look at how things like systemic racism, or the significant stigma that people who use substances experience, or even the healthcare system itself, the way our services are designed and organized and delivered, and how these really limit access to care. So we know that the structure and design of health services can impose a profound barrier to socially disadvantaged populations who may end up systematically excluded from programs, of course, resulting in worsening of health inequities. And so rather than focusing on numbers and statistics, what I'd like to do today is really highlight some of the challenges that we see in terms of the design and the delivery of cancer services that may be contributing to these inequities, or further widening inequities among those who already experience them. And so my focus here today on the challenges within the healthcare system and even at the healthcare provider level is not meant to ignore other determinants of health or broader structural issues, but really to make a case for the importance of taking action within our systems of cancer care. And as a way to sort of organize myself in doing that, I'm going to move through the cancer continuum. And so starting off with cancer screening and prevention, quite a significant focus on screening within the literature. We've seen actually several scoping reviews that have noted this disproportionate focus on cancer screening when compared to other points in the cancer continuum. And we know from this research that people who experience inequities, for example, people who have lower levels of income, unstable housing, people who've recently immigrated, have lower rates of participation in cancer screening. But we also know there are other inequities beyond just screening rates. So for example, among women with intellectual or developmental disorders, abnormal mammogram results are less likely to be investigated compared to those women who don't have an intellectual or developmental disorder. And so why might this be? What are some of the challenges that we're seeing in terms of cancer screening? Much of the literature regarding low screening among various groups that are often labeled as marginalized really assumes that low screening is a result of individual deficits. So there's really an assumption that these patients lack something. They lack education, or they lack awareness or understanding of the need for screening. But in reality, what we often see is poor patient-provider relationships, and the broader context of patients' lives is much more of a barrier, so to speak, to cancer screening. We know that discrimination has significant impacts. Obviously, patients who do not feel respected or who do not have trusting relationships with their healthcare providers are less likely to go for screening. We know that the structure of clinic appointments, which are usually a maximum of 15 minutes, really creates a mismatch between the complex underlying needs of patients who experience marginalization and the current clinical realities, which often include high patient volumes or mandates around efficiency. And so healthcare providers are really challenged to meet patients' acute care needs while also wanting to integrate health promotion and preventative care. Looking at a cancer diagnosis, we know that people who experience social disadvantage are at increased risk of late-stage cancer diagnosis compared to those who do not. So for example, a Canadian study demonstrated that people who experience a high degree of marginalization will have about a 40% higher risk of late-stage oral cavity cancer diagnosis than people who don't experience marginalization. Several Canadian studies have found that First Nations peoples are diagnosed with late-stage cancers more frequently than non-Indigenous Canadians, really because of a constellation of social and structural factors. And then on the flip side, we also see evidence that those with higher income are more likely to be diagnosed with cancer at an earlier stage. And we know that cancer stage diagnosis has a very significant impact on patients' treatment options and on cancer outcomes, and is really an important indicator of the quality of and access to care. And so what kind of challenges are we seeing within the healthcare system here? There's not as much research concerning diagnosis, but we do know that at times people who would be considered marginalized have their health conditions discredited or dismissed. their health concerns discredited or dismissed, and therefore, not investigated at all or not fully. For example, people with serious mental illness report having, legitimate physical symptoms dismissed as symptoms of their mental illness, and then much later are diagnosed as cancer. Patients who experience various inequities are sometimes labeled as drug seeking and don't have their physical health concerns investigated in a timely way. Some research has demonstrated how institutional cultures or specific organizational practices can be harmful. So for example, in their research on cancer and mental illness, Sinding and colleagues found that organizational practices channel people who have a previous diagnosis of mental illness towards mental health service providers, regardless of their presenting problem, which can have some serious implications at the diagnostic stage. And in terms of institutional policies, a really good example and a common problem is that of appointment booking or missed appointment policies. This was something described to me repeatedly in my own research by oncology nurse navigators as a huge challenge in the diagnostic phase. So for example, one nurse told me about a patient suspected of having colorectal cancer and who needed a colonoscopy. At the time, he could not afford to pay out of pocket for the bowel prep solution that's required before the colonoscopy. I think it's about in the range of $20. He was receiving social assistance, and there was some, really significant challenges in trying to get that cost covered. And in the process, he had to cancel and reschedule his colonoscopy several times. And the nurse navigator told me how this 3 strikes policy almost prevented him from getting through the diagnostic phase. In terms of cancer treatment, we know there are inequities related to who will be referred to an oncologist. So for example, those experiencing the highest levels of material deprivation, which is a proxy or index measure for socioeconomic status, were significantly less likely to be seen by a medical or radiation oncologist after a confirmed cancer diagnosis. There's also inequities in terms of who receives treatment. So for example, we know that patients with history of severe psychiatric illness are significantly less likely to receive guideline recommended treatment for colorectal cancer than patients without that history. And so just like in the diagnostic phase, we know that certain groups of people will have their symptoms diminished or dismissed, which is sometimes leading to inadequate assessment and management of symptoms during cancer treatment. So again, what is going on here that we're seeing these inequities? We know that patients' social circumstances and access to social determinants of health do play a role in treatment decisions and how patients move through that treatment phase. We know that stigma and discrimination and racism can unintentionally play a role in who is referred for treatment or even how treatment is offered. Sometimes these, really negative experiences with healthcare providers actually impact patients' capacity to continue with cancer treatment that they've already started. And even if patients are treated respectfully, sometimes our physical and clinical spaces of our hospitals and cancer centers can feel intimidating and unwelcoming. And this is particularly true for Indigenous peoples who, because of our colonial history in Canada, personal experiences of trauma, even just entering into a healthcare institution can be re-traumatizing and may create challenges to accessing cancer treatment. Unfortunately, we don't know a lot about the specific inequities in terms of survivorship care, but we do know that there are some challenges in terms of how survivorship care is designed and delivered that mean these services often do not meet the needs of people who experience health and social inequities and may actually exacerbate these inequities. So for example, Truant and colleagues describe how most cancer survivorship services are designed with a specific patient type in mind. So this would be the 50 to 7-year-old woman with breast cancer diagnosis who lives in an urban area, has a high socioeconomic status, has good extended health benefits, good work and family supports, quite a high capacity for self-care and self-advocacy, not a lot of lingering treatments, side effects from treatments. And so survivorship care may very well meet the needs of those who already have a fairly high degree of advantage and privilege. But they are often not designed to accommodate the needs of people who are experiencing marginalizing conditions or circumstances. And we also know that within cancer care, services are often focused on addressing biomedical or physiological needs, really at the expense of broader social or psychosocial needs. And finally, we know that accessing palliative and end-of-life care can be a significant challenge. And we know that patients who are experiencing poverty, unstable housing, may not be even within the formal healthcare system. So it's, can be really challenging to identify who is in need of care. If they are able to access palliative care, these services, might not acknowledge the real burden that's placed on them by pressures just to meet basic daily survival needs. Often healthcare providers tend to perceive addressing social needs like housing, food, income, transportation as outside of their scope of practice. And yet we know it is really only when those needs are met that some patients are even able to access care at all. Again, I feel like a bit of a broken record, but stigma and discrimination are very problematic. We know that people who are without homes and have substance use challenges experience significant discrimination and stigma when accessing healthcare services, sometimes to the point that they refuse referral to palliative care because they really just do not trust healthcare providers. And then there are some specific institutional expectations or assumptions. For example, that every patient has a house or a home, and this can make it difficult, if not impossible, to arrange for some care. Now, I've talked about inequities within various points of the cancer continuum, but looking across the continuum, there's also gaps between many or all of these points. Anyone who's worked within the healthcare system knows that it tends to be designed and operates in silos. And this lack of continuity can create some significant challenges for people who are already experiencing disadvantage, who at times will, sort of fall through the cracks. And increasingly, health systems and our systems of cancer care are really relying on patients to coordinate and monitor their own care and advocate for themselves to receive appropriate care. There are lots of narratives and ideas around patient-engaged care. And this can be really problematic for people who are experiencing marginalization or the effects of racism or discrimination or stigma. It can be very difficult to do those things, to exercise power that you really don't have. And one last point I'd like to make, which I think has been made in some of the examples I've provided, is that it can be quite difficult to tease out where there are inequities and what specifically is going on. Often the challenges that we are seeing in the health system, patients' individual circumstances and their access to social determinants of health, as well as their social location, the impacts of that social location, and other factors all sort of intersect and overlap to create or worsen existing inequities. And I point this out just to reiterate that these are very complex problems that obviously do not have simple solutions, and I'm not here today to offer a simple solution. But I hope that the inequities and challenges I've described sort of give you a sense that these are very major issues with significant impacts on patients and families. And without addressing some of these challenges, we will continue to see widening health and cancer-related inequities. And so how might we move forward towards equity-oriented cancer care? Well, we know that attention to health equity within healthcare organizations is growing. The Institute for Healthcare Innovation in the US has been surveying healthcare providers over the past few years. And in 2019, about 25% of healthcare providers surveyed indicated that health equity is one of their organization's top 3 priorities. And that number actually rose to 58% in 2021. And we're also seeing this increased attention to equity within the cancer care sector specifically. I'm currently leading a team conducting a scoping review looking at health equity in the cancer care sector. And we can see in our preliminary analysis over the period of 15 years, there is more and more research, but also policy documents, reports, strategic plans that are outlining equity goals. A great example of this is the Canadian Partnership Against Cancer's recent work, which names equity as a strategic theme and has really woven that through all of the work that they're doing right now. We've also seen in research that we have reviewed growing calls specifically for equity-oriented cancer care. And so there is a real opportunity here to leverage this attention and interest in health equity. We are still very much in the early days in terms of the work that has and still needs to be done. But I'd like to just highlight some of the exciting work that's going on here in BC in terms of equity and cancer care. We have the EQUIP program of research here at the UBC, which was co-founded by Dr. Annette Browne, who is one of my supervisors. And EQUIP is really an interdisciplinary program of research focused on developing and implementing strategies to enhance an organization's capacity to provide equity-oriented healthcare. And although, you know, the EQUIP program of research hasn't expanded formally into the cancer care sector, much of the work going on that I'm going to talk about really draws on EQUIP's take on equity-oriented healthcare by foregrounding issues of racism, stigma, structural violence, and how these impact healthcare access and health equity. Led by Dr. Stajduhar at the University of Victoria, the Equity and Palliative Care Collaborative conducts research and develops resources and services really aimed at improving access to quality care for people who are facing end of life and who also experience inequities like homelessness, poverty, isolation, racism, stigma, and so on. More recently, we have a multidisciplinary team funded by a convening and collaborating grant through Michael Smith Health Research BC. And this project is being led by Drs. Leah Lambert, Michael McKenzie, and Sally Thorne, and is really about bringing together healthcare providers, operational leaders, academics, and other partners to develop a clear understanding of the current issues in terms of equity in the cancer care sector, and to identify where there are opportunities for research and practice changes to promote equity in cancer care. And the impetus for this grant was really a group of folks in both clinical and academic spaces who are quite committed to doing some work, some meaningful work around equity. And this team also includes myself, Dr. Browne and Dr. Stajduhar. And then there's my postdoctoral research, which is looking specifically at equity-oriented healthcare in the cancer care sector, and I'll talk more about that in a moment. And so much of this work is very much closely linked, reciprocally informing each other and tied together by our understanding of how critically important it is to figure out how we can change our systems of care and redress some of these inequities. So I've mentioned equity-oriented healthcare a few times. Not everyone may be familiar with what exactly that means. So really the essence of equity-oriented care is that adequate resources are directed to those with the greatest need. Equity-oriented healthcare really aims to recognize and reduce the effects of inequities on access to healthcare and social determinants of health, to recognize and reduce the impacts of intersecting forms of racism and discrimination and stigma, and to recognize and reduce the frequent mismatches between how we usually deliver care and the needs of people who are actually impacted by inequities. Equity-oriented healthcare approaches also make a very explicit effort to build trust, make people feel safe, make people feel welcomed and accepted for those who are often considered marginalized or vulnerable. The EQUIP program of research has developed a framework for equity-oriented healthcare that's really grounded in 3 key dimensions, and those are culturally safe care, trauma and violence-informed care, and harm reduction. And I won't discuss these in detail, but through their work, they have developed strategies to guide organizations in really enhancing capacity to deliver care that is equity oriented. And these strategies are really meant to be tailored to a specific healthcare context. If you're interested, you can go to equiphealthcare.ca for a lot more information and resources on equity-oriented healthcare. And so equity-oriented approaches really provide an opportunity to improve health and healthcare equity at the point of care and within organizations. And so what might this look like in terms of cancer care? Earlier, I raised the 3 strikes policy in the context of cancer diagnosis, going for colonoscopy, but similar policies exist in terms of chemotherapy and radiation therapy. So for example, if a patient misses 3 radiation treatment appointments, that might mean that they are not welcome to continue that treatment. And these policies really, not only limit patients' access to care, but they also limit healthcare providers' abilities to tailor care to individual patients and to be responsive to inequities in individual life circumstances. And so if we were to integrate equity-oriented healthcare strategies into the cancer care context, this might look like, providing wraparound services that address social determinants of health or other challenges to help patients get and continue with the care that they need, while also perhaps revisiting and revising some existing policies. But we also know from EQUIP's research in primary care and emergency care that successfully integrating some of these strategies presents specific challenges and really depends on the organizational context. So for example, there are likely specific endorsements needed from leadership. There may be shifts in organizational policies needed that make it possible to implement some of the strategies that need to be implemented. And we really don't yet know what this might look like in the cancer care sector. We really don't know what organizational characteristics or contextual factors that influence capacity for equity-oriented cancer care, what those things are that need to be in place. And so as part of my postdoctoral research, we have started looking at what types of strategies and interventions have been used in the cancer care sector elsewhere, and what are those factors that facilitated their success. As part of the C2 work at BC Cancer, we are looking specifically at how health equity is being discussed as a goal or an aim, and what kinds of actions are supporting those aims. In the second phase of my research, we are going to be using some critical ethnographic methods to really dig into, what are those organizational and contextual factors that need to be in place to support or to enhance capacity for equity-oriented cancer services. This will include partnering with BC Cancer, but also other organizations outside the cancer care sector that maybe have already successfully integrated equity-oriented approaches into their services, and really learning from some of those organizations. And then we are going to work with stakeholders in the cancer care sector to develop some recommendations really targeted at the organizational level to enhance capacity for delivering cancer services that are equity oriented. And the long-term goal, the pie in the sky goal that we are working towards, will be to design and implement and evaluate organizational level equity-oriented healthcare interventions that are specifically tailored to the cancer care sector, really in hopes of making our systems of cancer care more equitable and more accessible. And I'm going to leave it at that. I would be happy to answer any questions by email. And I would be curious for those healthcare providers, leaders, policy experts, researchers, what you think we need to pay attention to in terms of addressing or responding to inequities within the cancer care sector, and some of the challenges that you may be seeing at the organizational or systems level in terms of delivering care that is equity oriented. But again, please feel free to reach me by email. My email address is at the very top. And then we have Dr. Annette Browne and Dr. Kelli Stajduhar, who are my supervisors, as well as Dr. Leah Lambert, a collaborator at BC Cancer. Thank you very much for your time today. I hope this has been helpful.